Now, this is a marvelous opportunity for you to ask any question or any clarification or even remarks or suggestion, anything.
Really, I have a question from regarding the presentation about the health education in Sri Lanka, and it's nice to hear that the approach of the family planning services and how they have delivered the message to the ordinary people. My question is, how do you assess the impact of the message in terms of their particular objective of the containing the population? Anyway, we can see that the population growth has got a very big impact of all these activities. But how do you directly relate or indirectly relate those activities with the population growth and population control over there?
It's a very interesting question. Actually, I thought about it when doing the presentation also so I anticipated that question. Actually, now from what I have presented, that is very much about the material that I collected from Family Planning Association and the National Archives. So Family Planning Association does not have a well-documented history in terms of the resource center is not functioning anymore, I'm sorry. So, and also I have material from the Family Health Bureau as well. So the impact was in the 1950s and 60s, of course, how they have, the number of letters they got from the people asking for about certain methods and about how to do it, kind of thing. That is why I showed the advertisement about confidentiality, the Rahasigatai advertisement. So that says a lot about analyzing the letters that they received from Sinhala medium as well as from Sinhala language as well as from Tamil language. Generally, they haven't received any letters from English medium. So then analyzing that only, the annual report says this much of letters arrived, we received, and these are the questions that they generally post. That's how they have taken into consideration how much effect that particular poster campaign had on people, on the public. So I don't know exactly how to do it now because we are not keeping any records of any of these. So actually I would have loved to see those letters, but I'm sorry, it's not available.
With that, I have another question. It's a very short one. It's really, I know that history repeats every time. Now, the contraceptive pills were earlier called as the sterile pills, or Vandapeti. Now again, that the same concept has arrived. So how do you analyze as a sociologist or historian these concepts repeat in relation to the behavior and the psychological aspect of the people? And I think even Sanjoy can contribute that one.
In my opinion, actually, I presented another paper 1 week ago in Zurich about Vandapeti, the sterility pills. So to an audience of course, social scientists, but Tamil speaking and also Muslims. That was I was so scared of presenting it, thinking, oh my God, they will look at me as a Sinhala Buddhist. But no, they were very happy about my presentation. That is because what I pointed at was public health sector should take sterility pills, the term, seriously, and the discourse around it seriously. Because the moment that comes out, that is why I traced it back to 1969, saying this is not the first time we are hearing it in 2018, but 1969. So this is exactly the link, reproduction of the nation. So don't take women's body as reproducing the nation. No, everybody, every woman in any particular country, the women health should cover the women's health, not only reproduction. So that is why after 1994, the International Conference for Population and Development speaks about getting out of targets, getting out from these numbers, and the whole Malthusian way of looking at population and development, and look at development in your own way. That is exactly what Sri Lanka is lacking. So public health, I personally believe that public health sector, together with the government, have to do a work hell of a lot on this, saying, look, women's health, men's health, everybody's health is important. So look at health as health. And also look at it as that whether we are delivering it to the whole population without leaving anybody behind.
Thank you. When one looks at the history of recent international health, one sees themes of sterility, sterilization as being immensely controversial themes. Because ultimately it is also often a judgment by a group of people about how a much larger group of people should behave. So in India, during the pox eradication program of the late 60s and early 70s, side by side, you have the family planning movement happening as well. And the problem there, of course, was one of the most shameful episodes, in my view, of Indian history happened, where young Muslim men were literally taken off the street and forcibly sterilized. And this was based on a subjective, very subjective use of population data that suggested that India's population problem was caused by uncontrolled birth rates, which was attributed to the Muslim populations of India at that time. Now, why do I say subjective use of data? It's subjective simply because when you look at the data as a raw sort of resource and then start analyzing it fairly and in an open-minded way, what you see is the urban-rural imbalance. That is, people in rural areas in India of all religions had large families. Why? Because during interviews carried out by anthropologists, at a time when the primary healthcare movement is being advocated by Havdan Mala from within the WHO, and there are some stakeholders within India of that ideology and the need to improve universal health coverage in primary healthcare, what they find during these interviews is that people are saying that, I don't know how many of my children will die, and therefore I need a large number of children so that when I'm old, I can ensure that at least one or two of my children are alive to look after me in my old age. So there is a logic, another logic, which often the healthcare workers in India from the 1970s would not listen to because they had their own targets. Now, what this suggests to me is that in the 1970s, you have the smallpox eradicators, you have the primary health care advocates, you have the population control, the family planning people. They're all representing healthcare, but they're working in very different ways. So using the recent history about the theme that Darshi has spoken so eloquently about in relation to India, what is clear to me then is that this is not a monolithic structure. This is a structure that is often working at cross purposes. And therefore, it suggests to me that I think integrated, collaborative approaches can work because once you communicate, if the anthropologists who were doing the interviews on behalf of primary healthcare had communicated, perhaps more effectively, with the people working on family planning, then information would have crossed over and perhaps you would have had a more integrated, more patient-oriented, more target-oriented communication of the problem. So these are things that we can see in the archives, but first we must recognize the complexity of the healthcare structure before we can go to the archives, Because otherwise we'll end up only looking at one program and writing just a very blinkered, narrow description of a program. So which is why I think I so enjoy working on these seminars with all of you, because there's so much we can learn about the complexity of your structure, the healthcare structure from you, and then we take that knowledge back, and then we hit the archives, and with the knowledge you give us about the complexity of your healthcare structure, we then study the history, the recent history of that structure, and then perhaps come back to you with information like Darshi has, which surprises you. And it's that element of surprise that I think then promotes collaboration. And we can, I think, really use this type of recent history to enrich current policy measures.
Yes.
Good morning. I'm Dr. Sandanayak. I'm a registrar in medical administration. So you spoke about using a model of recording the medical interview and analyzing it to find out the faults there in order to improve it. And at the beginning of the lecture, you said it's about a 7 to 8 minute interview. In our setup, in the outpatient departments, the interview will last for about 2 to 3 minutes. Do you think the same kind of methodology can be used to improve that such a short interview? Would that be possible?
Okay. Yeah, so maybe I say a little bit about this and the chair or others can add to it. Indeed, in our data, but even, in our own everyday experience, we know how much doctors and clinicians in the hospitals the world over are under tremendous time pressure, and how healthcare systems put a lot of thinking, and deliberation into this question of the time that is spent on a consultation. So we have clinics where, dozens and sometimes hundreds of patients waiting to get to see the doctor, and the doctor is sweating away trying to get through the consultations. And the general perception is that, because of this time pressure, the doctor simply has to get on with his business and convey whatever information he needs to convey to the patient as efficiently and quickly as possible, and then get on to the next one. And so in that process, if the patient cannot fully understand what he's told, there's not much we can do about that, because to lengthen the consultation would mean taking away time from the other patients. That is the general understanding. And there may be some truth in that. But on the other hand, when we look at the actual interactions, as we did just now as an example of it, you look into the details. In that particular example, for example, we saw that the doctor who approached the task of making a recommendation in a particular way by laying out not only the different tests that the patient needs to do, but also the relationship between the tests. In other words, in order to eliminate, systematically the possible causes of blood in the urine and so on, I need to do A, B, C, and D, and so on. Having laid out the land, if you like, the view of the land, then to make the recommendation actually turns out to effectively reduce the time that is spent on the consultation. So the second example that we saw actually took only about 1.5 minutes for the job to be done. The first example took 7 minutes, and at the end of the 7 minutes, the patient was still wondering what these tests were about. So efficiency is not a simple matter of the doctor just giving out a lot of information in a short time, but to do with the understanding, the level of understanding that can be achieved within the time that is available for the doctor to deliver his message.
Okay, thank you very much.
So in the United Kingdom's National Health Service now, there's an immense pressure on the GPs. And I understand from my friends and collaborators in the National Health Service, Britain's National Health Service, that now there are quite firm guidelines about how much time a GP can give during each consultation, including suggestions that GPs use stopwatches, making sure that they don't spend more than 15 minutes per consultation. Now that in itself immediately places communication challenges. How much time do you spend listening to a patient, and how much time do you spend then talking to a patient? And then you have to factor in the time of writing up a prescription and signing it as well. So are there such time pressures in the contexts that you've been researching?
Well, luckily, so far in Singapore, I'm not aware of such tremendous pressures on the doctors, and to the extent of suggesting them to keep a time stopwatch. But nevertheless, there is such a pressure, simply in the form of, as I say, a list of patients that you have. The doctor needs to get through. In the morning session or in the afternoon session, there's a whole list of names on his computer, So there is a real pressure there. But what I'm suggesting is that actually we don't look at this in a simple way as a need for the doctor to just keep talking as fast as possible, to give information as quickly as possible. In that way, sometimes you can end up being counterproductive. In fact, the more information you give, the less understanding you get back. So, in fact, I think one lesson that we can learn from the data is that the doctor can actually take a pause from time to time to check the patient's understanding and to allow the patient to have a chance to come back. Because in our field, we know that the best proof of understanding is in a response from the one that you're trying to convey a message to. But if the guy never gets a chance to come back to you with any kind of response, then you never know how much of what you say to him is actually understood. And you may be wasting the precious few minutes that you have, trying to say, a lot of things to him without actually achieving very much. So of course, there's a balance to be made somewhere, but I think there's something to be said about letting the patient say a bit more in that interaction, because after all, it's going to, it should, this consultation should take the form of give and take, back and forth, and there's not enough of that in many of the consultations that we see.
To add to what KK has said, yes, in the hospitals, they don't stipulate. They're not going to say give you a bad grade as a doctor if you pass the time in consultation, but they do stipulate for normative running of the hospital. They hope, as a guideline, that you have 6 minutes. So 15 minutes is very, very generous in the UK.
It's also free.
Oh, so free as well. Yeah, I just want to add to that.
I'm Dr. Lushan Jayasuriya, former Additional Secretary, Ministry of Health. I was interested to hear about this doctor-patient relationship discussion. As far as I am aware, in Sri Lanka, we have not really studied it at all. We have had the sense that we have having too many patients, and doctors' main job was to clear the patients. Large numbers come to the outpatient department, and you clear them. And whatever is said is said. And it's more dictatorial way of saying, you shall do these things. Take these medicines and come, do these tests and come, that's it. But I think now the time has come. In Sri Lanka also, we are talking of quality, not quantity. We have quantity. For the young people like Dr. Sandanayaka, who are taking over the ministry, to do real studies and to improve the situation. This is not true, this business of getting rid of patients is not true only of the government health sector. But even if you go for private practice, private consultations, still the patients are being cleared. The consultant sees 50 patients in the evening. So how can he talk to them? So the time has come. But because I am saying this especially because today we hear of stories of having 50 MOs OPD in a hospital, large hospital, medical officer OPD. Or out of them, only 10 are working in the morning. Others are not there. Or there are 6 hours, they are supposed to work for 6 hours a day, but they are working only 2 hours a day. Maybe because there are no facilities. There are not even enough tables and chairs for them to see patients. So, time has come for us to look at this. How we are clearing patients, how we are looking at patients, how we are talking to patients. And we expect the patients to know. I have personally become a counselor to my friends now. They go to a consultant. They get a prescription, they get something, then they come to me. Why? They want to know what has happened. I take half an hour because I have time. Tell you exactly what has happened. What is this drug for? Why have you been asked to take this drug? They don't know. Why this test for? They don't know. So there is a lot of work for us to do. Thank you.
Yeah, I really fully agree with Dr. Lushan Jayasuriya. And one of our administrators also pointed out regarding the time slot. Actually, when it comes to smaller institutions, hardly any patients, very small number of patients to attend. They bypass the smaller one and come to the larger ones. If we heighten the image of smaller institutions, they will utilize more. We really ensure the best care at the closest hospital. Then overcrowding will be minimized and all the patient will have a good doctor-patient interaction. So, and I agree that when more doctors are at the OPD, they, separate the hours among them and they minimize the number of consultations. So that is not the case. And another thing is one specialist in a hospital usually conducts only one clinic per week. Why not they conduct another clinic? Always clinics are conducted morning and we have never thought of doing. There are clinics in the afternoon, but still, usually one clinic per specialist. So that also we can really improve. So in that line, if we think, Dr. Lushan Jayasuriya pointed out, we can do some interventions and see. And as Dr. Samarage is sitting in front of us, this came to my mind. During his time at Base Hospital Panadura, you really established the appointment system for outpatient department. I can remember. Good management of queues. Because our patients, they are used to come all in the morning. But all cannot be seen at the same time. So if we can allocate time for them, don't come at 8. As per their convenient, we have to allocate. So if some can come at 10 o'clock, then 11 o'clock, 12 o'clock, so that overcrowding is not there and convenient for both ways. So we have a lot. So together we have to change the system. Yeah, you can briefly tell about Panadura Hospital, what you have done.
Panadura, I think recently there are a lot of improvements that they are following now with the digitalization and communication. Dr. Samantha is there. But I want to bring in another dimension. Now we are going for this reform, what you mentioned, trying to have that primary care level improve. Yes. I think before, I have been telling at all the meetings that when they were planning this project, health sector development project to streamline, I was telling first, don't try to do various things and then various models are put forward. Just our system has developed over several decades and years. So if you try to, there have been several failures in the past when we tried reforms. The DHO system, the DDHS system all failed. So now the new one is also going to fail unless what we have to do is just study this interaction, see what is wrong. Without doing that, we are doing various changes. The basic fact is that they want to have a family practice model in the primary care levels. So the first thing is to study what is happening now and correct that, identify those needs and give a good training. The EPI program, CDD program were very successful because there were workbooks and all the workers were send through the mill and everybody understand, even the midwife clearly understand what's happened. Now we have a very good, successful EPI program and it's did. So similarly, this aspect, communication, that is the basic thing. We need to study that first and then see what is wrong and then develop good training. Now training programs, I see even the ministry, just put down some topics and get lecturers and do it. Not that sort of thing. Really identify the needs. Behavioral change we need to do. It's a very intensive, the crux is the skill-based training, especially communication skills has to be improved. And congratulate bringing this health communication into limelight. Thank you.
Really, I can make a little input to Dr. Samarage's thought about the system improvement. We have a good opportunity at this moment since we have got a lot of specialists at the grassroots level. Now we have got a family physician and they really work at the district hospital level. And same time at the regional director office and the provincial level, we have a community physician. They really work at the community engagement. And meantime, I think we have identified community pediatrician as well. They are the people who can deliver the services and they improve the structure. Therefore, it's a good opportunity at this moment. But as Dr. Samarage mentioned, we need to have a good situation analysis and we need to understand the real gap between the services and the necessity. Therefore, I think if we can do something in a collaborative way with the other sectors, then we can understand the situation and improve the communication gaps.
Yeah, can I just add a quick remark to that? You know, I'm in full agreement with Suranga. And of course, you know, the suggestion that the first thing that needs to be done is to actually look into the actual situation to see what problems there are and, you know, how one could possibly tackle them. You know, so the empirical study is very, very important here. An empirical study also in a particular way, not just, for example, you know, we're used to questionnaire surveys, and we have done that ourselves. And it's useful up to a point because questionnaire surveys give you some idea of, you know, the level of satisfaction and so on and so forth. But on the other hand, when it comes to the actual consultation, what can be done to improve the quality of the consultation and so on, these are questions that are very hard to collect useful data from in the form of a questionnaire survey, for example. So we've done this kind of questioning before, and typically what you get is the patients will, because they're already after the consultation, you try to keep them in the clinic for a few minutes, ask them some questions. First thing, a lot of them are keen to get away, to go home, right? So they answer your questions very quickly, maybe, but you know, they don't want to stay too long. And it's not the best time to reflect upon these things. And sometimes if they do, they are willing to stay and think about it, they may still want to just say that it went pretty well, quite well, you know, and the doctor did his best, you know, to be fair to the doctor and so on, but without actually reflecting on particular practices that could be improved upon or could be changed. So there's nothing like the actual thing, if you like, you know, when you capture a video recording of a consultation, then in that recording, and through a detailed analysis, you can get a lot of insight from it. So I would very much like to be able to interest some young doctors, physicians, or, you know, medical students or any other student who may be interested in this kind of research to work with us. Because we need doctors and students from Sri Lanka who know the language and the culture and the system and the practices to actually be able to apply the methodology, which is generic, you know, but you need the local knowledge and the local understanding to make some good use of that method.
Anybody wants to answer? I expect answer for that question because they do something for that. Suranga, you want to speak?
So sometimes back, the main trade union, which all doctors belong to, started training the doctors on communication skills. We have about 19,000 doctors in the service sector, and I was part of that team. And we, up to now, we have only been able to train about less than 1,500 doctors. And with our setup, it's usually our audience is about 100 doctors, which is not the ideal for training communication skills. And in about 2 or 3 programs, before the start of the program, we did some recordings using simulated patients. And we are yet to analyze the data, and the data will be available soon. Hopefully we can share the data with you. Thank you.
Okay. No, I thought you will answer this because now in Sri Lanka, in every hospital, we do conduct patient satisfaction survey, no? So I thought you will answer the question raised by the Professor Luke. You know, we are conducting patient satisfaction survey twice a year. We have given from the healthcare quality and safety, patient safety directed to all the institutions. The questionnaire, the same questionnaire is being implemented throughout the country. And we have given the software even, they analyze and they present every quarter. They come to the center and they present their progress. So now we are heading for, from patient satisfaction survey, we are heading for patient experience survey. So we can yield. We are doing that. Halfway we are there. But we want you to analyze those responses and act accordingly.
Thank you, Chair. One question for Professor Luke. Just to the ethical, I was like concerned about the ethical, the whole ethics about doing that, video clip, and also to listen to doctor-patient discussion. And also mentioning about the point that you spoke about, not to interview or ask them to fill up a form as soon as they come out of the clinic. I would thoroughly recommend, I did lots of interviews with Well Woman Clinic patients. I don't want to say patients, the women who came to Well Woman Clinics, and I never interviewed them at the site. I always went to their places, their houses. I visited them individually and spoke to them while they were attending to their household chores. But if you are really interested in public health and if you really want to make an effort, that is exactly how I would say, because I got lots of information about how they are being treated in the clinic and because I looked at pap smear, after reproduction, how women looked at their bodies. That was my question. So I spoke to them about their timetable and how much time they can allocate within a day to look after themselves, maybe to comb their hair, because sometimes they just do household chores until the first child come home after school. That was such a, they were really, they came out with lots of good things that where we can use to improve our public health sector.
Just quick response to that. Yeah, very good question and very good suggestion. So on the question of the ethics of the research, our university, like other universities in Singapore, follow the highest international standards, mostly the US standards for these things. So for any such research to be done, to be even started, we must obtain approval from what is called the IRB, Institutional Review Board of the university, which has clear requirements and guidelines about what to do. So for this kind of research, for example, we must describe in detail what the research, the purpose, the procedures, the protocol, and so on. And to make sure that, for example, when we use the data, all the participants must be anonymized, so we don't know who they are. And as you see from the presentation, when we need to show the actual video, we show it in the we call it the X-ray format, which becomes kind of black and white, and in reverse as well. So you can't see who's who, but you can hear the interaction, the words that are used. Also, many other considerations to protect the participants, including both the doctors and the patients. And to also impress upon the doctors when we obtain their consent that this is done not to be critical about particular persons, but for the good of finding patterns in the interaction which can give us thoughts for enhancement and so on. As for the post-consultation interviews, I think your suggestion, we will take up that suggestion. It's very good. Yeah. Thank you.
That's very, very true. I'm a director at the Ministry of Health. When I was running in charge of hospitals and we did our patient surveys, as Madam said, I think asking it on our own turf, the response is very different than asking it when they're on their turf and they can answer honestly. They feel a bit, under pressure to give us the right answers. So that's a very valid point. And I certainly, found it difficult sometimes to accept some of the findings that we came up with because, it looked pretty biased, in truth. Overall, I'd really like to say that I have always thought that clear communication was essential for success, especially in a sector like health, which is a service sector. It's one of the soft skills that I think has to be there at every level in our sector. So I'm very grateful for this type of seminar. My issue, if at all, is sometimes when we are working in collaboration with foreign organizations and maybe there's funding attached to it, or say like an organization like say with sensitive issues like the family planning. They have slogans, they have agendas which we have to bring into our country. And as you quite rightly pointed out, if it is not something that we can just implement. As Dr. Samarge pointed, we need to do an analysis of what is on the ground first to understand what changes need to be made, and then also see how do we apply this in our context, culturally sensitive, in a language that our people understand best. And the message isn't necessarily sometimes the same. It may have to be modified. And my struggle has always been where we've had to collaborate with other organizations on their agenda. And that isn't necessarily what we may need. And that can only be found out if, as Dr. Samarge quite rightly pointed out, if we have a baseline, if we understand what's going on and what our needs are first, before we make the transition into something better, hopefully. Thank you.
Any more questions? Okay. I think as Honorable Minister is still having the meeting, he asked me to wait to see whether he can come, and if not, to present to his speech. So I will do that now.